day and welcome to my short presentation on neuroendocrine tumours. I'm Dr. Grange, a general practitioner in Namibia, and I'm currently doing my postgraduate diploma in endocrinology. In this presentation, I'm going to be discussing some specific NETs with a focus on their syndrome symptoms. Endocrine tumours are very rare, comprising only 2% of all cancers. They sometimes occur as part of familial endocrine syndromes such as MAIN 1 and 2, von Hippel-Lindau syndrome, but may also occur sporadically. There is an old saying that goes, when you hear hoofbeats, you think horses, not zebras. However, it's important to remember the zebra. These rare, slow-growing tumors with their non-specific symptoms are known as the zebras of the cancer world. As one of my tutors always said, what the mind knows, the eye sees. It is my hope that after you've watched this presentation, you will know more and feel more confident in recognizing NETs in future. So, what exactly are neuroendocrine tumours? Neuroendocrine tumours, also called NETs for short, arise from specialized endocrine cells which occur throughout the body. The most common sites are the gastrointestinal tract, specifically the small intestine, appendix, and rectum, the pancreas, and the lung. Other less common sites include the breast, prostate, thymus, and skin. Tumours generally not discussed under the topic of NETs are pheochromocytomas and paragangliomas, medullary thyroid carcinoma, and adrenocortical cancers, but they are also from the same neuroectoderm. NETs were previously termed carcinoid, meaning cancer-like, giving the impression that these tumors were benign. We now know that NETs may be benign or malignant, the same as any other tumor. NETs may be functional or non-functional. Functional tumors produce peptide hormones which cause symptoms, and non-functional tumors are often found incidentally or on autopsy. How do NETs present? The presentation of NETs is varied and often syndromic. Carcinoid syndrome is a condition that results from serotonin hypersecretion. This results in vasodilation, bronchoconstriction, and smooth muscle contraction. The common symptoms here are flushing, watery diarrhea, bronchospasm, hypertension, and right-sided valvular heart disease. This syndrome generally only presents after metastases to the liver and distant sites, as the normal inactivation of these hormones would occur in the liver by monoamine oxidases, but is now bypassed. Gastroenteropachic NETs, or GEP NETs, usually present in the 5th and 6th decade of life. They are difficult to diagnose because they present with vague and non-specific symptoms, and are often incidentally discovered after surgery for another problem, such as after an appendicectomy. Appendiceal NETs are generally non-functional and benign, and occur more frequently in women, most likely due to more frequent laparoscopic surgeries for lower abdominal pain. Gastric NETs are classified in 3 types. Type 1 is associated with chronic atrophic gastritis with or without pernicious anemia. Type 2 is associated with Zollinger-Ellison syndrome and multiple gastric ulcers. Type 3 occurs sporadically, and they present as large solitary invasive tumors. They cause a rash that's a bit different from the rash of carcinoid syndrome, as it's patchy, tortuous, and intensely itchy. Colorectal NETs are more aggressive and have a poorer prognosis than that of adenocarcinoma. The 2 types that are classified are moderately differentiated neuroendocrine carcinomas, which are generally treated with surgical excision, and small cell carcinomas managed with chemotherapy. Pancreatic NETs have a variety of syndromes produced by a variety of hormones, and they are commonly associated with multiple endocrine neoplasia type 1. Insulinomas caused by an excess of insulin is characterized by Whipple's triad and hyperkalemia. Gastrinomas present with Zollinger-Ellison syndrome and severe peptic ulcer disease caused by an excess of gastrin. This generally occurs in the absence of the usual risk factors. Pancreatic polypeptide secreting tumors, or PPOMAs, present with weight loss, jaundice, and abdominal pain. Lipomas cause watery diarrhea, hypokalemia, and achlorhydria. Glucogonomas produce a paraneoplastic phenomenon in the presence of 4Ds: diabetes, dermatitis, which is also known as necrolytic migratory erythema, deep vein thrombosis, and depression. Somatostatins generally suppress pancreatic, biliary, and intestinal secretions and cause a syndrome that is characterized by gallstones, hypoglycemia, and steatorrhea. Pulmonary NETs are divided into typical carcinoid, atypical carcinoid, large cell neuroendocrine carcinoma, and small cell lung cancer. Centrally located typical carcinoids are generally more benign and result in recurrent infections, chest pain, cough, wheeze, dyspnea, and pneumonia. More distally located carcinomas are generally asymptomatic and are found incidentally on imaging. These have no association with smoking. Atypical carcinoids are generally associated with smoking and frequently found in men. They are generally situated peripherally and as such present quite late and are often metastasized at presentation. Small cell lung cancer is also associated with heavy smoking in male patients and causes fatigue, cough, dyspnea, anorexia, weight loss, pain, and hemolysis. Mediastinal and hilar lymph nodes are often present on imaging. Metastases occur frequently to the bone, brain, liver, and adrenals. Several paraneoplastic syndromes, such as the syndrome of inappropriate ADH secretion, Cushing syndrome, and autoimmune neuropathies and encephalomyelitis also occur. Pheochromocytomas and paragangliomas should be suspected when the classic triad of headaches, which is often due to hypertension, tachycardia, and excessive sweating occurs. Medullary thyroid carcinoma is a tumor of the parafollicular or C cells of the thyroid gland. It secretes an excess of many peptide hormones, most notably calcitonin, producing few symptoms in the early stage and may be palpable as a neck nodule or throat nodule. It's really painful and may cause diarrhea. Cortical carcinomas occur in the adrenal cortex and produce an excess of many hormones, and symptoms here include weight gain, proximal muscle weakness and insomnia, androgenism, and hirsutism. How are NETs classified? The classification of NETs is based on their biological behavior, and the three features we use are the grade, the differentiation, and the stage. The grade is an expression of the tumor's aggressiveness. For this we use the Ki-67 and the mitotic rate. The grading of NETs is of utmost importance as it is a key determinant of the patient's prognosis. Differentiation refers to the tumor's resemblance to the normal tissue surrounding the tumor. Well-differentiated tumors closely resemble the surrounding tissue, and poorly differentiated tumors do not. Grades 1 and 2 are generally well-differentiated, while grade 3 tumors are poorly differentiated. The staging of NETs refers to the extent of tumor spread throughout the body, and it is a little more complicated than that of other tumors that only use the TNM system. Early tumors may be completely resectable, while advanced tumors which are either locally advanced or metastasized are not generally amenable to surgery. How are NETs diagnosed? A multidisciplinary team is essential for the diagnosis of NETs, including many specialists like oncologists, surgeons, interventional radiologists, and pathologists. Tissue samples may be obtained from either resection or core needle biopsy, and this is mandatory to make the diagnosis and to grade the tumors. Syndrome-specific biochemical testing is based on the symptoms and signs at presentation. For patients with carcinoid syndrome or a small intestinal mass, a 24-hour urinary 5-hydroxyindole acetic acid test is required after the avoidance of serotonin-rich foods for 72 hours. For all NETs, chromogranin A is a very good biomarker, which helps to assess the tumor load as well as the disease progression. Imaging for staging includes the CT of the chest, abdomen, and pelvis, and an MRI of the liver may be required if more detailed imaging is desired. Functional imaging with radiolabeled somatostatin analog PET CT scans take advantage of the somatostatin receptors present on the cell surface of well-differentiated NETs. For poorly differentiated tumors, an 18-FDG PET CT will allow localization of these tumors because they readily take up radiolabeled glucose molecules. Intraoperative endoscopic imaging is very useful to localize small pancreatic lesions. How are these NETs then treated? Many factors should be taken into consideration when planning the treatment for NETs. This includes the tumor site, grade, stage, differentiation, symptoms, age, and other comorbidities. Surgery with negative margins and lymphadenectomy in localized, well-differentiated tumors is the only curative modality we have available. Primary small bowel NETs should be resected to prevent bowel obstruction in the future. Surgery is also important in metastatic disease, and debulking of metastases reduce secretory symptoms and improve survival. Adjuvant-based chemotherapy is recommended for fully resected but poorly differentiated tumors. Watchful waiting is an appropriate treatment plan in patients with low volume, asymptomatic or non-functional metastatic disease. When medical therapy is required, long-acting somatostatin analogues, octreotide and lanreotide, can reduce symptoms and improve progression-free survival. Targeted biological therapy includes everolimus, which is an mTOR inhibitor that inhibits cell proliferation, angiogenesis, and cell metabolism, and it is used in GIP and lung nets with good progression-free survival. Sunitinib, a multi-targeted tyrosine kinase inhibitor, inhibits angiogenesis in pancreatic nets. We have a new kid on the block as far as treatment modalities are concerned, in the form of PRRT or peptide receptor nuclide therapy. A therapeutic radiolabel is attached to a somatostatin analog, which concentrates in and delivers cytotoxic radiation right to the tumor. For poorly differentiated metastatic cancers, chemotherapy can show a dramatic and rapid response, but relapse is common and the overall survival is less than 1 year. In conclusion, early recognition of NETs will prompt the appropriate investigation and referral. This will give the patients the best chance to live a long, happy, symptom-free, and progression-free life. Thank you for listening.